Chair, yet another CME. 987 is a sequence. जो लोग फ्लैश खेलते हैं उनको पता होगा, अच्छा नंबर है।
897
सर ये 987 होगा तब भी मैं ये 897 is the number. Sorry, I am corrected. हाँ 987 भी आएगा तब भी मैं चेक करूँगा। Friends, I chaired the last session when we were listening to one of the budding legend, international cardiologist. तब मैंने आपको ये कहा था कि आजकल कितना एडवांस हो गया है साइंस में और इन जनरल कि जब ट्यूबलेस टायर में पंक्चर लगाना होता है तो बिना खुले लगा देते हैं, ये इंटरवेंशनिस्ट करते हैं। और अगर ट्यूब वाला टायर हो और उसका पंक्चर लगाना हो, जो हम पहले देखते थे उसको मार के हथौड़े सारे टायर का बोथा सुधार देते थे, आजकल वो ऐसा नहीं करते हैं। आजकल वो टायर को आराम से खोल लेते हैं। दे हैव डिवाइसेस टू ओपन द टायर विदाउट बीटिंग, विदाउट टॉर्चरिंग। सेम इज बीइंग डन विद आवर कार्डियोलॉजिस्ट surgeons. The surgeons are not opening all the cases with sternotomy, so they have moved much as the interventional cardiologists have moved. So they are competing with each other in advancement technology. So going about advances in the newer say ways of surgery in the cardiovascular system. They have minimal invasive surgery and totally endoscopic vascular surgery is possible now. So we will listen from the legend. Dr. Rajneesh is one of my best friend as a cardiothoracic vascular surgeon, and I still remember he gave us one of the best outdoor CME. In 14th August 2016, I still remember Dr. Tulsi, Dr. Kapoor, Sudhir Kapoor and Dr. Prashar. They were the different segments of our triangle and it was Tiranga. और क्या हमने उस दिन अंताक्षरी का आनंद लिया था? Sir, we are indebted for that CME and I wish we have one more in the near future. Sir. मेरा काम डॉक्टर चौहान ने आसान कर दिया, इनके बारे में इतना कुछ बोल दिया। अब तो मैं यही कह सकता हूँ भाई ये KGMC के ग्रेजुएट हैं, फिर उसके बाद कानपुर में उन्होंने MCH किया, उसके बाद आउट ऑफ कंट्री सो मच ऑफ एक्सपीरियंस। 30 years is not a little time. 30 years of experience, majority at Escorts, then at Medanta. Of course, with Dr. Trehan, who was, I won't comment, he was just like Lakshmikant Pyarlal for Kalyanji Anandji. Well, now that he is in charge of cardiothoracic surgery at multi-specialty Max Hospital, Saket. And I have referred him many patients and I am fully satisfied. And I wish all of us give him a chance to prove his worth. और जहाँ तक interventional cardiac interventions and surgery vis-a-vis where they stand, हम ये भी कह सकते हैं कि 100 सुनार की एक लोहार की। जब सुनार से काम नहीं चल रहा तो लोहार से करना पड़ता है। और आजकल लोहार में भी सुनार की नज़ाकत आ गई है, वो कहानी नहीं है कि वो it will be more traumatizing. So, not going too much into details, sir, I invite you for your talk, and I presume we will learn newer techniques which are now available. And in the end, we will have interaction. I will rather suggest keep your talk not too lengthy, so that we have more time for our interaction. We have very inquisitive audience. So our question and answer will be remembered more than your talk. Thank you, sir.
Very good.
Good evening, everyone. At the outset, I would like to thank Abbott and Dr. Sushil Chauhan and the Physician Forum for giving me this opportunity to the evening. As Dr. Kalra rightly said that we have been associated for very long, and it has always been our pleasure to be associated with the Physician Forum. And since the time I think we got associated with the Physician Forum has also has become one of the most reputed forum where the physicians can exchange their knowledge and their thoughts and their interactions. And as I was just discussing with Dr. Gupta, I was saying that we should be listing this Physician Forum in the Guinness Book of World Record. I think there is no forum like this which has conducted CMEs for 20 years. No other organization, no nothing can do it every week, on every Wednesday, even in the COVID period. So it's remarkable. And it is remarkable just because of not for one person, the entire group which has been really contributory, which has been really coming over here. As Dr. Chauhan said, there is no CME if the physicians are not there. So everybody really needs a applaud. I would say personally to that. And it is really an honor to be talking to all of you because a presenter or a person who presents and there are people to listen to that, that only really makes it sensible. Because I have been to CMEs where only the people who are presenting the lectures are there, they are only there. And they are the national level CMEs. It's not. So only people are there, 5 people, 6 people, and then just make each other listen to what you are saying and then you just come up. So I would say, let's begin with this. So my reason, I have presented this talk some time back also. So my first reason for presenting this today, I just want to make you aware of all the latest changes, what are happening in the field of granular heart surgery. Because as physicians, you are the first point of contact. Any patient who comes to you, has got a valvular problem, he's going to really ask you that what kind of a problem I have, what should I do, what are my chances of survival, whether I will really living after this, whether I should get the surgery, where should I get the surgery, should I do a minimal invasive, should I do a sternotomy, should I do, what will be the cost. Today morning I got a call from Dr. Tulsi, he was asking me, sir, वो जानने वाले हैं, वो कह रहे हैं 12-13 लाख रुपए की सर्जरी कर रहे हो आप, क्या कर रहे हो? मैंने कहा सर सर्जरी तो जितनी की है, the surgery involves the cost of the valve also. Surgery तो उतनी महंगी नहीं है, because they have chosen that kind of a valve, so that is why we are having it. So basically, sir, so this is the whole idea that if I can communicate my point of view and let you know that what is the current situation, where we stand, and what are the things we can as physicians tell us, because your patient is going to listen to you. If I tell them that okay, this is what you require, this is what you do, he may not agree. He may not agree fully that, because then he says okay, I'll go back to my physician and ask him, and then take a decision that what needs to be done. So for next 20 minutes or 30 minutes, I will be talking to you about changing landscape in the valvular interventions and how the technology has made things much safer and better for our patients. So let us try to understand the problem first. So what is the problem of a valvular heart disease? So around 3.5 million patients in India suffer from valvular heart disease, which is a very big number. Like 35 lakh people require some kind of intervention because they are suffering from valvular heart disease. Rheumatic fever or rheumatic etiology has come down, but still one of the major reasons for involving valvular hearts or valvular valves of the patients. In fact, 96% of the valvular pathologies requiring surgery are rheumatic intervention. So that is a very big number. If we look at this chart, unfortunately, India has not really, gone, I would say, is almost matching the share of Africa or, the real third world countries. So we still have got rheumatic population, and 73% of the global rheumatic burden is coming only from the 5 developing countries, which is a two-thirds of it, which is coming from countries like India and other developing, Bangladesh, and other African countries. So which is a very huge number. And the unfortunate thing is because it involves the younger patient at average age of 30 years, 48 years. So when it is involving the patients who are in their productive years, productive life, then they get affected. Then the whole the things change because it has got social impact, it has got the impact on the country, it has got the impact on their families, on everywhere it has got an impact. And in India, we think, as I just told you, 97% are rheumatic, congenital are only 1.5%, and the other are 0.8 and 0.3%. So rheumatic heart disease constitutes a major valvular pathology, and mostly the valve which is involved is the mitral valve. More than 50% is mitral valve. Isolated mitral valve is around 50%. If we combine mitral with aortic, it is another 34%, and then around 16% aortic, and so on. So mostly the patients who have valvular heart disease, they are the patients, they involve the mitral disease, the mitral heart disease. And this is how the pyramid is. If we just look at the 4 lower blocks, is the situation where the things are still salvageable. The rheumatic heart disease patient has got some symptoms, goes to the physician, he auscultates the patient, finds some kind of a murmur, patient has got fever or symptoms suggesting a rheumatic fever. He starts antibiotics, he just refers the patient for the echocardiography, and then the earlier the treatment is done, then the patient is still very much treatable. But if the disease goes beyond that, then the disease of the valve goes into, say, the patient has got severe mitral regurgitation, or patient has severe mitral stenosis. So the patient goes into the heart failure, and when the patient goes to heart failure, then it goes to the cardiologist to manage, or the cardiologist is going to manage. And if certain things go beyond that, then we are at the top of the pyramid, when the patient comes to us, where we have to offer the treatment to the patient and say that what we need to do. Again, the mitral valve is the most commonly involved valve. Among the mitral valves, 50% of these patients, 48% of these patients have got severe mitral stenosis. When they seek treatment, if the disease has already become unsalvageable, or the valve has got so much damage, the valve gets calcified, the subvalvular apparatus becomes calcified, degenerated, and then most of the time we are not able to salvage these valves. Means like I am not able to repair these valves. Because what we need, that we want that we should be able to repair these valves. But many a times when the patient comes to us, these valves have so much disease that we can't really do much. And as the age advances, the graph shows that the mitral incidence starts coming down, but the aortic incidence keeps on going with age, both in males as well as in the females. So this is basically in a nutshell what the problem in India we face. Anyhow, the patient, this is the problem, the susceptibility of the younger population in India, patient with the lower socioeconomic status. Screening facilities are limited, not every hospital, not every clinic has got an echocardiography. And when the insufficient primary healthcare services are there, and then it has got the economic burden for surgical interventions, a lot of our patients cannot really afford any surgical intervention because most of these patients have got surgical, they can't afford it. So as I was saying, when the patient is asymptomatic, it can be managed by the general physicians and the general practitioners. But if the patient becomes moderately and severely involved, the cardiologists and the cardiac surgeons are the ones who have to really deal with these patients. So this is the major cause, as we had discussed, the 97% of our patients. But another 2-3% of the patients who are, who get their valvular involvement are the patients with aortic stenosis or patients who have got degenerative valvular disease. Mostly it is aortic stenosis, and you will be surprised to know 5% of the patients who are above the age of 70 years, so they will have some kind of an aortic involvement because of the degenerative pathology. So 5 people out of 100 people who are above 70 years. That's why you would have seen that these days a lot of our physicians or cardiologists are doing cardiac valves or transcatheter valves because the incidence is very high. And so far we were not really looking at it. So that is, again a significant number. And then patient in the child-bearing age who were previously overlooked, they were not taken care of. They are also the patients who are now being diagnosed. Children, basically, we were not really doing much about, not doing any surgery for the children. Now we have got valves and the techniques available where we can offer surgeries to children. Although the numbers are very minimal, but the incidence is here. Treatment options, as I said, first management is the medical management or prophylaxis. It is applicable, it is possible only in certain number of patients, but beyond that it is not possible to manage them medically. Then other thing is doing a balloon valvotomy or commissurotomy. That we do in balloon patients who have got mitral disease and in some patients of aortic disease where it is like a life-saving measure. And then definitive treatment is either a repair of the valve or replacement of the valve. Balloon valvotomy or BMV or CMV, or you might have heard about it. The BMV is being done by our cardiologist colleagues where they open the valve with a balloon, but mostly the mitral valve. So there is certain prerequisite for a mitral valve. The patient with mitral stenosis comes to you and says, "Sir, इसकी ballooning हो सकती है कि नहीं?" So you can just see whether this patient does not have a mitral regurgitation. Mild mitral regurgitation can still, we can do a balloon valvotomy, but moderate or severe you cannot do a balloon valvotomy because the valve is already leaking. And there the valve and the subvalvular apparatus should not have any calcification, there should not be a lot of calcium there because the calcium is there, so you cannot really open the valve properly. And there should not be a clot formation, there should not be a clot in the left atrial appendage. As you would know, mitral stenosis patient, most of them will have atrial fibrillation, and because of the atrial fibrillation, majority of the patients who have got mitral stenosis would have a clot in the left atrial appendage also. So that also becomes a risk. So in these patients, surgery is the only indication, surgery is the only possibility, because if you try to do a balloon valvotomy, the clot can embolize, the clot can go from here to any part of the body, it can go to brain, cause a stroke, or can block any of the visceral organs. And again, the aortic valve, aortic balloon valvotomy is just done as a life-saving measure. When a patient is almost like crashing, you just open the aortic valve and then take the patient for either these days we do transcatheter valves or for the surgery. So balloon valvotomy has got a very limited role. Valve repair is the treatment of choice. Suppose I get a patient who has got mitral regurgitation or mitral stenosis, my choice first is to try to repair that valve. Reason being, because we are preserving the patient's own valve. Because whatever the nature has made, that is the best thing. There is no valve like that, there is no tissue or a mechanical or any kind of a valve like that. So your own valve is the best valve, you try to repair that. But unfortunately, as I just mentioned, couple of minutes back, because patient come to you so late that you can't really repair those valves because the valve is already damaged. And then you need a team who can really, who is well versed for doing this, a good experienced surgeon who can repair the valve. Not every surgeon is well trained to do the repair. And most of the advantage of these valves is that you don't really need to give anticoagulation or any kind of a therapy in the post-operative period. Most of the patients with small dilated dose, they do very well when we are repairing these valves. So, but as I said, many patients are not available for valve repair, so then the option becomes the valve replacement. And valve replacement for any trained surgeon is one of the easiest things. We can replace a valve in 30-40 minutes. And of the procedural time, then another 2-3 hours for other things. And it's a very fairly standardized procedure. I have been doing heart surgery for more than 32 years now. I mean, I would have done, I would say hundreds of it, or thousands of it rather. So you can do it in whichever way you do it, either through a sternotomy, through thoracotomy, through the right thoracotomy. So whichever, there are different ways of doing it. I will just touch upon that in some time. So, and the valves which you have to choose, either we have to choose a mechanical valve or a tissue or a biological valve, or we do a transcatheter valve, we call it a SCAR. So again, the question comes for the physician that what should we do? So because the problem is that we have plenty of options available. So if you look at this, so this is the mechanical valve, this is another mechanical valve, this is bi-leaf thread, this is a single leaf thread, these are the tissue valve, this is another tissue valve, this is a transcatheter valve. So you have to really choose, and again you have to answer that which is the best option, which is the best choice for that patient. And if we look at this scenario of surgeries, what we have been doing, since 2020 to in 24 years, the number of the surgeries which have been done in India have really multiplied manifold. In 2001, we were doing total valve cases of around 8,000 to 10,000. Today we are doing around 120,000, which is a very significant number, which is further increasing. The problem with that, where we are going to change the valves is the premium quality valves, the best valves, as I mentioned in the morning, are expensive. They come with a cost, because they are made by multinational companies, they have a cost of as high as 5 lakh rupees. So you and pay for the surgery, say 3-4 lakh rupees, and pay for the valve, which is a very expensive valve. Mechanical valves are relatively cheaper, but they have to give anticoagulation, and every patient is not suitable for a mechanical valve. Tissue valve, the problem with tissue valve is that these valves may require reoperation because they tend to degenerate. I'll just touch upon it. And follow-up is again is healing. And as you can see, there are plenty of valves there. So a lot of valves, mechanical, a lot of tissue valves. So you can very easily say there is not one single perfect valve. There is not a valve which you will say, okay, if there is one valve, I will choose it for patient lifetime. So this is none. So because you have to really choose according to the patient, according to the patient age, requirement, patient's lifestyle, and so many other things, what you have to choose. So if I have a choice, I will literally give one patient one single valve, which is going to last forever. So this is our criteria of what we follow in our practice, and this is based on American guidelines and European guidelines. We have just what we have done. We have reduced the age by 5 years. We reduce the age by 5 years because our longevity is, I would 5 to 10 years lesser than the people who live in European and the Western countries. So what we follow, patients who are below 50 years of age, we offer the mechanical valve unless the patient really asks for a biological or a tissue valve. Patients who are above 60 years, we offer them a tissue valve, which is going to last for say 10, 15, 20 years. And then the patient who are between 50 to 60 years, we always discuss with the patient and the family that what is your lifestyle, what life expectancy you have. And the aim is our valve should last for the patient lifetime. So this is what our aim is, and this is what we try to do. And women in the childbearing age, generally we do not give them a mechanical valve because the chances of bleeding during delivery are very high. And these patients who have got mechanical valve during pregnancy, the teratogenic effect of the warfarin and acid trauma are very much there. So although I have patients, I have got plenty of a lot of patients, the young females or mechanical valve who had multiple deliveries, 1, 2, 3. And they are doing well, there are no deformities in children, but it is not really recommended. The guidelines do not say this. They say if the woman is in childbearing age and wants to have a family, you should offer them a biological valve. And elderly patients who are above 70 years and have got multiple comorbidities, in these patients we offer them a biological valve. So as I just mentioned, with any procedure, there are two components to it. One is the cost of the valve, and the other is the cost of the procedure. The cost of procedure remains constant. If I just give you an example of mass, it is in an economy ward or in a twin sharing ward, the cost of the valve will be something around 3.5 to 4 lakh rupees. The cost of the valve will differ. The procedure cost is like 3.5, and the cost of the valve will start from say 40,000-50,000 for mechanical, up to 5 lakh for a biological valve, depending again on the patient cost, a patient choice, and what the patient wants. Anticoagulation and thromboembolism is a problem with a mechanical valve. I just operated 2 days back one patient who had similar this thing. The patient had, this is the third time I operated this patient. I operated 15 years back, 10 years back, and this time again the patient comes to me. He lives in somewhere in a rural area in Lucknow. He came to me with the thrombotic and a stuck valve, and I had to operate the third time. And the poor guy had to really sell off his everything to just afford the third treatment. And he was not able to even walk for a couple of steps. He was short of breath, with heart failure, and the valve gets stuck. The leaflets do not open, and I got a problem. So, these are the different mechanical valves. When I started doing surgery, I started cardiac surgery in 92, 93. Then we were using ball and cage valves. So this is a cage where a ball was there, this is a ball. We used to get in there, and we used to put, this was called a star Edward valve, which was one of the oldest mechanical valves which we were using. Then we had single leaflet valve, the Yorkshire valve, even now this single leaflet, we have got Shri Chitra valve, which is the Indian valve, which is still available and being used in the south. We no longer use it in the northern part of India, but few surgeons in the south use this. These are the single leaflet valves. And nowadays we use the valves which have got bi-leaflet valves, or which have got 2 leaflets. These are the mechanical valves. So the 2 leaflets give you an advantage because, as I just gave you an example, the one leaflet gets stuck, the other one is still moving, and when the other one is still moving, there is some blood going forward. So at least patient can reach the emergency hospital, where can reach the cardiac surgeon, and then we can either thrombolize or do a redo surgery or do some surgery for the stuck valves. And there are future developments happening. The valves are becoming less thrombogenic. Now we are looking for synthetic materials which are going to make valves. Like the material where you would not really require any anticoagulation. They are just synthetic material which are not going to really regenerate. Human trials are going on even in India, and they are looking forward to a couple of years time we'll have totally a synthetic material which will be the valves will be made of. And then, as I said, thromboembolism and hemorrhage are the 2 major problems with mechanical valves, because if you do not maintain the PTI and prothrombin time and INR of these patients, if you give too much of the medicine, the patient have tendency to bleed. They can bleed in the brain, in the stomach, in the knee joint, anywhere. And if you could give a little less, then the problem of stuck valve is there. So the problem incidence is 2.5 to 5% every year. And this is a journey of a mechanical valve. So 4.5 to 5% problem every year. So you operated a patient at the age of 50 years. By the age of 65, either he will require another surgery or he will succumb to any other complications in the problem. So this remains a problem, so that is what you have to really take care of. And the first generation tissue valve, this is a journey of a patient with a first generation tissue valve. You operated a patient at the age of 50 years, and then he has a problem rate of 4 to 5%, but at the age of 60-65 he will require another surgery. And then we just go about. The major advantage of a tissue valve is that you do not require anticoagulation, because then you don't need to maintain a PTINR. And if you are not maintaining PTINR, then the restrictions, the dietary restrictions, other things are not there for these patients, and the patient have got a relatively better life. The trend in US is that most of the patients in US now have biological tissue valves, and up to the tune of around 90% of the patients. But if you look at India, biological valves which were very less, better than 2 or 3%. So 20% of our patients have got biological valve, which is a really very good incidence. And there are research which is going on to make tissues which are better, which are going to last longer for in the patient body, which are going to last for 20 years or more, so that we can avoid another surgery, the second surgery which I showed you. So younger patients obviously require, when they are going to live longer, they require a valve which is going to really last for a longer time. And so this is what we have to really choose. It will depend on the position where we are going to put a valve. It will depend on the access, whether we do with a sternotomy or minimal invasive or a transcatheter or a robotic. It will require whether we use a stented or a stentless valve, or whether we use a pericardial and porcine valve.
I think it is indication for binding.
You stop up. Just another 2 minutes. I think I was thinking that I was trying to make you understand things. I think it's really going overboard. Not really. I will say, look. So what the biological or the tissue valves are? So biological valves are like the human valves, and then we have got animal valves. You will say the human valves. Why not we use biological human valves in all the patients? Human valves are homographs. We take it from the cadavers and we use it. Unfortunately, again, everywhere it is not available, and these homographs also do not last for long because of the immunogenicity. We were using these homographs, cadavers, we were procuring the valve and then we were putting it, but it is not done now. Autographs, we still use it. You might have heard of procedures named as Ross procedure, which is done in children. The children who are below 15 years. So what we do, these patients, if they require any aortic intervention, so we take a pulmonary valve of the patient and put it in the aortic position. And in the pulmonary valve, in the pulmonary position, we put an artificial valve. Because patients tolerate pulmonary regurgitation and stenosis better than aortic stenosis and regurgitation. So this procedure is called as Ross procedure, which is very much done because younger patients do grow. When they grow, so they have got their own valve, which is just swap the position from pulmonary to aortic, and then we can do that. Animal, again, this is pericardial and porcine valves. We can use the porcine valves are the pig valves basically. So we take out the pig valves and then we just take out the original pig valve and then treat it and then put it in the patients. And then we have got pericardial valves. We take it. The pericardium of the cow and buffaloes, and the hands sew these valves and then make it. And then the 4 predictors, the durability, hemodynamics, and implantability. So this all depends. So younger patients who are ready for the future, I'll just finish in 2 minutes more, sir. Yeah. So early generation tissue valves were intact porcine valves, which were not really good. They will degenerate in 5 years. So now we have got next generation which lasts for 10 years, and now we are looking for the latest generation biological or tissue valves which are going to last for 20 years or more. This is what we are claiming. Obviously, when we put it in the patient's body, it may last for 18 years, it may last for 15 years, or it may last for 22 years, we do not know. But this is what we think based on our lab data. And then we think that these newer generation valves are being made by Abbott, which are our partner today for the CME, made by Medtronic and Edwards. They are all multinational companies which are making this. And they have made the changes in the material of the valve, the changes in the mechanics, changes in the hemodynamics of these valves, so that these valves last for a longer period. This is one of the latest Epic Max valve, which is made by Abbott. Again, it's a premium quality valve, costs something around 5 lakh rupees. But if it is going to last for 20 years in the patient, so then it is worth it because you escape another reintervention or a surgery. And then this is a Resilia valve made by Edwards. This is a pericardial valve which also works for longer. So the intelligent thing what the companies have done, because these valves, if suppose a patient requires another intervention, can be dealt without any other surgery. To give you an example, we can do valve in valve. Means a person who requires surgery at the age of 50 years. Suppose I have put a tissue valve and that valve lasts for 20 years or that valve lasts for 15 years. So after say at the age of 65 years or 70 years, we can do a valve in valve. Means like we can put a valve without surgery, by angiography, transcatheterally, a TAVI valve can be put in a valve. So you get another 10-15 years. So 50 years plus 15 or 20 years, like 70 plus another 50, 80, 85 years. And if you have to do the third valve, again you can do a TAVI. Or you do a 50 years trans tissue valve, then another redo surgery at 65, 70, you put another tissue valve which lasts for 20 years, and the third is a transcatheter valve. So you save patient from anticoagulation and the problems related with it. So this is a valve in valve. And if we can avoid this, the second incidence, then the patient lifestyle and journey is very smooth and patient really has this. And these valves are the future. And we put tissue, sutureless valves also, which can be put to the sternotomy, thoracotomy, and then transcatheter valve. I think all of you know about it. Dr. Vijayka might have told you many times about transcatheter valves. Nowadays we do mitral clip also. Without surgery, we can repair the mitral valves. This is the mitral clip which clips the two leaflets of the mitral valve, and then you don't really have the patient will got leakage in the valves. We can put this. I think escape this because of shortage of time. This is how it is basically done. You go transeptally, puncture the interatrial septum and put a catheter there and the clip. And stop the leakage. And this is what our patients which are being done. You just check it on the table, do the transcatheter TE and do a 3D echo and just check it. And keyhole surgery or minimal invasive surgery has become standard of care. We do with all our patients, whatever I have told you, I can do with all minimal invasive either through a thoracotomy or through a very small anterior thoracotomy. This is an aortic valve replacement, again an aortic valve replacement. So take home messages. Nowadays we can tailor the treatment according to the patient choice. The treatment has entirely changed, the valve has entirely changed, the technology has changed, which gives us better quality valves which are going to last for longer period with less complication and problems, and which we can offer a biological valve to our younger patients. And we have to do a lifetime management of a patient. A patient comes to you as you plan the future of your child. That okay, this is what my child is going to be at the age of 15 years, 20 years, 40 years. So exactly you have to hand over your patient and tell that okay, at the age of 50 years you have this, 60 years I will do this, 70 years I will do this, so that you can take the care of the patient's lifetime and do the best possible thing for them. Thank you once again for your attention. And I will be more than happy to take any questions you have.
Sir. Dr. Rajneesh, please, इधर ही आता सर. Just have your say. Friends, we had a wonderful talk once again from the legend. I would like you to clap once more for a lovely talk. Sir, to check the ball rolling, although I think I will cut down my time in question answers because I have noted 25 questions, I will ask only 4. Sir, first of all, I just want to know, is your presence very much necessary when interventional cardiologist is doing some adventurous thing like TAVI or something like that? So, please clear my doubt. Are you required to be around because I am very required?
I think so that it is better if we are there, because when the problem happens in heart is usually time, especially in a cardiac procedure. Oh. That is why there was a concept of heart.
वो जो कहते हैं रिश्ते में तो हम तुम्हारे बाप करते हैं, तो वो सही है.
Sir, हमारे will say I have taken out transcatheter valves from the cath lab straight away. I mean, they have planted the valve, the patient, either the valve embolizes or there is some acute problem, then they just immediately shift from cath lab to our operation theatre. And that we have advantage in our hospital, we have on the same floor. So we are just 15-20 meters apart from cath lab.
I heard about hybrid type of operation.
So we can just shift the patient over there and manage the patient. And I have been able to salvage many of their patients.
To understand from you, to redo a valve replacement, is it better in valve which are mechanical or tissue valves?
So I think for surgeons, both the things we use you can manage both mechanical as well as tissue. Although tissue valves are a little difficult to explant because you saw the struts, they become part of the ventricle. So you have to really pull them out from the ventricle and put it. But I think an experienced surgeon can do both.
Sir, I will limit my questions. My one comment is about IIT Kanpur. They are coming up with LVAD, which is titanium made and kind of artificial heart, Jantra. And it is very less costly as compared to the other ones.
Yes. Basically, sir, IIT Chennai is coming up with the cardiac surgeon, Dr. Bala is here. So they have made an Indian model of LVAD. LVAD basically is done for heart failure patients. Here they do not get a...
They have to buy time and...
Not really. I have a lot of my patients who are on permanent LVAD therapy. So the cost of this LVAD is something around, procedure cost, Milake is something 1 crore or something. But if the cost of the LVAD is, they are saying, it will be less than 20 lakhs.
Yeah,
So 20 lakhs, so something around 30 lakhs one can do.
It is 20 lakhs now it is done, sir. And I read about Bivaccord total artificial, which was I think tried on 9th July.
Yeah.
And
so we have total artificial heart. What we put LVAD and other things, we put a valve or LVAD in the patient heart. And by this thing, the total artificial heart, you take out the patient heart altogether, put it in a dustbin and put a machine there. And there are incidences where people have survived for more than 6 months, some years. And then you have to really look for heart somewhere.
Sir, I forego my all question after Jamal.
It's a wonderful session, Dr. Rajneesh. I would like a wider participation. It's a very, very interesting topic, and therefore I'm sure that you would be having somebody in the family, God forbid, somebody in the friend circle, somebody in the neighborhood who must be having structural heart disease, and therefore you must be having some questions. Therefore, open up and ask questions to Dr. Rajneesh. He gave us a wonderful session. Dr. Moderator said is raising his finger. Just 2-3 questions, sir, before I come to you. Sir, you mentioned about TAVI. And TAVI in max costs about 20-22 lakh rupees. If you put the same valve surgically, what is the cost?
TAVI valve?
Yes, sir. You cannot put it surgically?
TAVI valves are designed differently.
They are
designed totally different. We put surgical valve made of same material, and those 20 lakh valves come to 2 to 3 lakhs.
So that is
5 lakhs which I am saying is the most expensive one. A regular tissue valve will cost something around 2 lakh rupees or 1.5 lakh rupees to...
So the longevity of the valve put surgically and by TAVI?
I think surgically is better.
Surgically is better. Sir,
because we still have results of transcatheter valves of 8 years. Whereas surgical valves we have data for 20, 25, 30 years.
So we keep hearing that the prosthetic valves, which are being put through procedures, transcutaneous procedures, there is an issue with the spontaneous degeneration. So, could you enlighten us about that, about the prosthetic valves?
So what happens? The prosthetic valves are both are called prosthetic valve technically, sir. Either mechanical or tissue valves.
I am talking about the tissue valves.
Tissue valves are called bioprosthetic valves or biological valves. So they do degenerate because they calcify. And when we are putting it transcatheterally from the femoral artery, we have to crimp that. We have to really squeeze it and then put it through the femoral vessel. So because the valve, when you are crimping the pericardium and all, so that can have some effects and that's why the valve can degenerate earlier than when the mechanical or surgical valve is being put. In surgical valves, we do not really touch the valve. I do not touch my biological valves with my hands. So they come from the packing and straight away when we put it in the patient. We are afraid that we will damage these leaflets. They are because if this is a porcine valve, it's a big valve, very thin leaflets. And if it is a pericardial valve, so if you touch that, you can injure the leaflets and that can have a problem. But both are designed differently, so that is the reason. So surgical valves basically have better longevity.
So you briefly mentioned about the metal valves. And majority of the talk that I found was concentrated on the aortic valves. Sir, when we were doing a post-elevation, we used to see a lot of rheumatic heart disease. So if it is a rheumatic aortic stenosis, or what we commonly see today, the degenerative aortic stenosis because of aging, is there any difference in the native valve in rheumatic heart disease and in degenerative aortic stenosis?
Yes. So degenerative aortic valve mostly they have aortic regurgitation, if we are just talking about aortic, and can have aortic stenosis also. But it occurs in the younger age, say 30, 25, 40 years of age. Whereas degenerative aortic stenosis occurs in patients who are above 70 years of age. As I said, 5% of the patient or people, general population above 70 years will have some kind of a degenerative aortic disease. And mostly it is calcific. There's a lot of calcium which gets deposited in the aortic valve, and then you just put valve within valve without taking out the valve.
Sir, one of the common conditions that we find in a younger population is bicuspid aortic valve.
Yeah.
Sir, what is your recommendation for follow-up in a case of a bicuspid aortic valve that is diagnosed accidentally in our clinic? How should we go about diagnosing? What should be our parameters for sending that case to you?
So, bicuspid aortic valve or congenital, sir, because it's the three leaflets that valve has only two leaflets. So, bicuspid aortic valve are more vulnerable for aortic stenosis. They are more vulnerable for aortic aneurysms and dissections and aortic aneurysm. They form much more in bicuspid aortic valve. So whenever we see bicuspid aortic valve, we should periodically follow these patients up. So at least we should do a echo yearly, and so that we can by echocardiography see whether the stenosis or the pulsation is increasing. If it is more than moderate, then we should do some intervention. Otherwise, we can land up in trouble or a problem all of a sudden. So that is the thing.
So you recommend doing a yearly echo at least?
But in a bicuspid aortic valve, because it's a totally entirely different thing, different subset of patients. Here we cannot recommend in bicuspid, TAVI cannot be done, and the other things cannot be done. So in bicuspid you have to do the surgery. So and the complication rates are much higher, so they have to be really managed in a different manner.
Sir, my last question. I'm sure you mentioned about the mechanical balls, and the cost was very tempting.
I think Sushant has a mechanical or model show to everyone. You have it?
The mechanical ball.
So please, if you can just pass it on.
On every table, maybe one mechanical. Sir, the cost was very tempting, 40,000 to 90,000 rupees. So if I had a poor patient, and I want a mechanical ball to be put by you in economy ward, what is the figure that I should tell this patient कि इतने में हो जाएगा?
So 40,000 is for
only for the valve.
Only valve, मतलब 3 and 4 lakh rupees.
4 lakh rupees. It's all done, sir.
Yeah.
Right. I will go to Dr. Odha.
So, thank you, Dr. Rajneesh.
Thank you, sir.
I think what Dr. Kalra first, it was not a question, it was a comment that whether surgeon is required in all cath lab. So I have heard Dr. Ashok Seth saying in a conference that whatever I am today, there is some contribution of our cardiothoracic friend because I have done many misadventures which were corrected by my cardiac surgeon friends. This was Dr. Ashok Seth's statement. So my question is in Rose procedure, am I correct? Name is where you replace aortic valve with diseased aortic valve with a normal pulmonary valve, and pulmonary valve is replaced by an artificial valve.
Yeah.
So My question is, aortic and pulmonary both valves are tricuspid, same, you can replace easily, same type of valve.
We interchange that.
So both are tricuspid valves. If rarely it is bicuspid, then you will not replace it.
Pulmonary valve is never bicuspid.
Very aortic can be bicuspid rarely. Yes.
So you
ये दोनों आपस में साधु होते हैं, साधु हैं.
Then what Dr. Chauhan also asked, the aortic stenosis in 5% you said can be due to degenerative disease in old age. So there you can do TAVI or some other prosthetic valve is required. In all degenerative aortic stenosis in above 70 years of age.
So we can do TAVI in most of the patients, but for TAVI we have to have meet certain criteria that we just do with a CT scan. We must see that what kind of aorta it is, how much the aorta is dilated, what is the coronary height, so there are the different criteria we have to see. If that patient meets those criteria, we can do TAVI.
Thank you.
Somebody has a question here? Dr. Mathur sir has a question.
Nice talk, sir. Thank you so much.
Sir.
My question is regarding a bacterial endocarditis. I have a relation of mine. She had developed after atypical pneumonia, bacterial endocarditis. She was breathless. She has still not controlled the seizures coming after antibiotics for almost 2 weeks, 2 weeks plus. Now, what is the role of surgery and when between? She has a medication and the mitral valve with regurgitation.
Sir, today only I was just mentioned, I operated a patient, she had infective endocarditis and a mitral valve, so I changed it. The patient was on 6 weeks of antibiotics, so the recommendation is that you have to give 6 weeks of antibiotics. And if the patient is not having severe acute regurgitation, so then it's an emergency, you have to operate those patients earlier. Or the vegetations are very big, they're like oscillating and they can embolize from the valve, like more than 1 centimeter. So then those vegetations will not get affected by, only cured by antibiotics. Because the risk of embolization in the brain and anywhere in the body are there. So those patients are to be operated immediately. Otherwise, in an endocarditis patient, we generally wait for 6 weeks. And once the patient is hemodynamically stable, have taken antibiotics, the blood cultures have become negative, and then you operate these patients.
Sir, the vegetation is only 2.7. Last echocardiography, it's a patient answer. So is there an indication now? She is already antibiotic for 3 weeks now. Is the time to operate or wait?
Sir, if the patient is stable, then give an antibiotic for another 3 weeks and after 6 weeks you can operate.
She is running temperature every day. 6 weeks.
Try to give, if the temperature is not getting better and hemodynamically she is deteriorating, the regurgitation is increasing, then I think
So we can wait for 6 weeks and continue the antibiotics and wait and watch.
Yeah.
Thank you, sir.
And she should be monitored in a hospital because we have to do periodic echo to see that the leakage, the acute heart failure is the biggest problem that the diabetic patient have. Suddenly the valve ruptures. So there has to be followed.
She was in the hospital the next second, Dr. Viveka. She stayed there 2 weeks. She's been discharged and antibiotics at home. Regularly IV antibiotics given by the sister. But weekly we reviewed and weekly we doing an echocardiography. So last echocardiography was done on Saturday. There are not shown any progressive improvement. So I'm very
I
concerned.
think then you have to intervene if the patient is deteriorating. Because otherwise we lose the patient. And another thing about endocarditis, even if we have changed the valve, we still have to give antibiotics for another 6 weeks. So like the patient I operated, she is afebrile and not this because I put a biological valve, I put an artificial valve there. So that artificial valve will also be vulnerable for infection. So we have to give antibiotics for another 6 weeks. And then
So the message continue antibiotic and wait and watch.
so last time I had operated a patient 2 weeks back who was on antibiotics for more than a year. He came from Bhilai. For 1 year he was bedridden on antibiotics, not getting better. Then he came over here, the mitral aortic, both valves are degenerated, and then we operated. Unfortunately, patient got cured and only today, he went back to Bhilai. So, endocarditis patients are one of the toughest things because it's not only the endocarditis. Because the endocarditis infection eats away everything. It's like infection anywhere. The mitral valve, it can eat the aortic valve also, it can eat the pulmonary valve. the aortomyocardium, it becomes like a big hole inside the heart. So you have to reconstruct the whole different, the annulus and then put the valve inside there.
So far, reciprocal vital wall. Then it can spread further.
Sorry.
So far, reciprocal vital wall only. But can it progress further more?
Because all four valves are near each other. Once it appears that they are different, for surgeon they are just sitting next to each other.
Personal question of Dr. Mathur sir has been worried about Sir ki samdhan.
Wanted to clear my doubt. Which antibiotic is given for so long? Which is the antibiotic which can be given for so long? Is it changed in between or?
So we give both generally according to the culture sensitivity.
We have to culture again.
Blood culture, we do paired blood cultures. So we do 6 cultures. Every time we take 2 cultures.
Okay.
And do it for consecutive 3 days. And then see which kind of the antibiotic is more susceptible. Otherwise, a broad spectrum gram positive and gram negative. And make us say and some gram positive. This is what we eat.
Sir, Dr. Vimal, every pediatric.
Sir, I work with Dr. Anita Saxena, Dr. Syam Sundar Kothari, SS Kothari, sitting. Sir, at what age we correct the valvular effect portion of top and which one is used?
So, basically, pathology patients are different patients altogether. So what they develop is pulmonary regurgitation. So they pulmonary, because they have pulmonary stenosis, we just do the LVOT and reconstruction. And we open the LVOT, left ventricular outflow tract. When we open the left ventricular outflow tract, they develop pulmonary regurgitation, a PR. Many patients do tolerate PR very well. But if they do not tolerate pulmonary regurgitation, then you have to change the valve and put artificial valve. You can do these with different kind of conduits and other things. But other than that, you don't do the aortic and the other valves are not really involved.
So he was talking about at what age? 6 to 12 months?
Cough generally is treated as early as possible. So nowadays,
There are 4 defects.
yes.
Which defect need to be corrected early and the last?
It's not, we don't do it in 4 stages. Nowadays we correct it completely. We do all the 4 things at one go. Yeah. So we do either as soon as the patient presents to you or at a later, so whenever the patient comes to you. The pulmonary hypertension is not irreversible.
Sir, Dr. Tulsi sir, but just before I give it to Dr. Tulsi for a prolonged discussion, sir, we know that valvular heart disease and pregnancy is a very complicated issue. And we have gynecologists here, we have Dr. Kiran Pasan here, and we have other lady doctors, Dr. Shireen also. I want to know if we have a case. Dr. Alka को mention नहीं करेंगे, she is my friend. Yes, hello. Which valvular disease, with pregnancy, must be corrected before we tell the patient to conceive? I mean, absolutely 100% instruction from us, do not conceive till you get this corrected.
So both mitral as well as aortic.
Both of them?
Mostly in female, it is the mitral stenosis, which is the commonest. Rarely the aortic, but it should be, both should be corrected. You cannot say that with aortic stenosis you can go ahead and have a pregnancy.
Have you ever done a surgical intervention in a pregnant lady, sir, a valvular intervention?
Generally, sir, you try avoiding it. If the mitral stenosis you want to do balloon valvotomy, but the risk of fetal loss are very high. Because if we are going to replace a valve, I have done it, fortunately patients are surviving, but you have to put the patient on a heart-lung machine for a valve replacement. And you have to fully heparinize, right? So the fetal loss is very, very high. More than 50% chances are there. So you can have fetal loss. You generally do not do this unless it is a life-threatening or it's a life-saving for a patient.
सर बस आखिरी क्वेश्चन है मेरी तरफ से सर आपने मैकेनिकल वॉल्व की बात की एंड वी नो दैट इफ यू पुट इन अ मैकेनिकल वॉल्व इट इज एंटीकोagulation फॉर लाइफ एंड इट इज पीटी INR business for life. So you also mentioned the biological valves, the tissue valves which you call, and you said minimum of anticoagulation is
For 3
required.
months. Only females.
And beyond that, sir?
Only aspirin.
Only aspirin, not even another antiplatelet.
Sir,
No, sorry.
sir. Single antiplatelet.
Single aspirin. Aspirin is
Right, more to Dr. Said, Dr. Tulsi.
भैया सारे गिलास में रखे हैं
Thank you, Dr. SAP is not me. And regarding valvular, yes. So regarding valvular interventions, so the current evidence favors and supports transcatheter valvular replacements as a frontline therapy today.
no, sir. Not for every age.
Not for everyone.
Not for every age.
Let me elaborate further before we intervene. In all categories, whether it's high risk, moderate or low risk. Is it a problem?
No.
So, after that partner 3 and the aggregate low risk and the dedicated trials, we know that the transcatheter interventions probably is very safe and efficacious in low risk patients as well. So, indications, incidence of coronary artery disease is very high in aortic stenosis, and especially in diabetics. They have multiple vessel disease, and cabbage and probably the surgical or the sever ACS with AS in younger patients. So what do you have to say about ACS in younger patients with AS? Sever probably or surgical aortic valve replacement along with cabbage is the modality of choice. Everybody says, sir.
So there are two things. When we talk about low risk cardio, low risk does not mean low age. No.
So let's talk about how you identify low risk patients.
So low risk patients, because the chances of their having surgical complication is less than 1%. Or we have got an STS data, Society of Thoracic Surgeons data, which has got a score where we score the patient and find these patients are very low risk of having surgery. So in those lower and intermediate risk, we can do TAVI. There are partner 3 other trials which have shown, but we do not have the long-term outcomes of these patients. The maximum
10 years
So
data.
we have 8 years, and you must see they regenerate, 40% of them degenerate. I don't want to go into that controversy. So if you know what is the biggest or highest surgery these days done in US is post-TAVI patient surgical replacement. That is the graph is going like this, because those valves are degenerating very high, and then you have to do surgical intervention.
So when you talk about degenerative bioprosthetic valves, so Jack recently last September and said nowadays the bioprosthetic valves are so durable that they last at least 15 to 20 years, as high as probably mechanical valves. So the durability of valves have improved now. What do you say about that?
That is what I was mentioning, and that was the whole crux of today's talk. That we have got very good biological valves, both porcine as well as bovine, which are available to us, which number one have got very long durability, and they are ready for TAVI. The companies have incorporated all the things in the first procedure. If the person requires a TAVI, it's already done. It's like you just have to put the valve. They have already done all the homework and what kind of a valve would be required, what kind of a intervention would be required. So this is already done. So that is the other advantage of these valves. So that's why these valves are at premium. Because the tissue valve you can get in 1 lakh rupees also and 5 lakhs also.
Let's talk a little about the NOAF. So new onset atrial fibrillation after TAVR is about 9.9% and is associated with increased mortality, strokes and extended hospitalization. What about in SAVR?
It's not even, I think, 1%. So
Friends, this is very noteworthy. Not even 1% in SAVR.
yeah.
the incidence of atrial fibrillation.
Yeah, surgically everything well because we are not touching the atrial appendage or the mitral valve altogether. So incidence of atrial fibrillation are very, very low. The mitral valve, yes, but not to the aorta.
What about the conduction, abnormalities or defects, the new onset left bundle branch block and permanent pacemaker implantation in patients undergoing SEVER?
Is less than 3%.
Less than 3%? Wonderful, sir. Finally,
The target is around 30%. Initially it was 30%, even today it is 10%.
okay. My clinic talked about porcine or bovine valves. So, what do you prefer? Do you prefer porcine over bovine valves?
I put both, sir. The valve which we are talking about, Epic Max, the abortic yes, a porcine valve. Otherwise, we use bovine valve also. So both the valves have its advantages and disadvantages.
Can we have some decorum at the back again? Okay, go ahead, sir.
So both porcine and bovine valves are equally good, sir, depending on what where we are choosing and what kind of patient it is.
So why Mayo Clinic said that the porcine valves are better as compared to the bovine valves was less calcification seen with the porcine valves,
Better hemodynamics, sir.
better hemodynamics, low risk of strokes as well
Yes.
with porcine valves. Okay, let me talk about as case. Can I dwell on a case? So a 40-year-old man, 48-year-old patient with history of polysubstance abuse, which included IV cocaine and amphetamine. So this patient landed in an emergency with acute decompensated heart failure, and hemodynamically he was stable except for diffuse lung crackles bilaterally, 5/6 diastolic heart murmur with pitted edema, both lower extremities, and after IV diuretics a TEE was done, which showed severe aortic regurgitation, left ventricular dilatation and hypertrophy with a normal ventricular function.
Yes.
So, he also had, Dr. Mathur read on this, he had large vegetations, in the cups, in the aortic cups and also in the coronary cups as well. So, patient, now, what would you do here? Would you give him a mechanical valve, or would you give him a bioprosthetic valve, or would you do a saver or a taver here?
So in the acute situation, first we have to stabilize the patient.
Done. IV diuretics stabilize the patient.
And see the endocarditis, the patient has endocarditis, again you try to give antibiotics for 6 weeks. Once you have done antibiotics for 6 weeks, patient is hemodynamically stable, then you either you don't do tower in acute patients, you don't do tower in endocarditis patients, never. So you always do a surgical intervention. You can take a mechanical or a biological valve, both have got equal incidence of.
So this patient preferred, he said, I would not like to hear the click of a mechanical valve. I would like to be on a lifelong anticoagulant, so give me a bioprosthetic valve. The surgeon, like Dr. Rajneesh Malhotra said, the chances of a redo procedure is high, maybe even after 5 years or 10 years. So he says, I am ready with that, I'll probably go ahead with that. So, as Dr. Malhotra said, probably, saver is the modality of choice here as compared to the taver. And after about 6 weeks of IV antibiotics like imipenem and other drugs, he was doing very well. And repeat TTE showed normal ejection fraction with absolutely normal functioning aortic valve prosthesis. So saver would be preferable here. Thank you, sir.
Yes.
Are there any other questions? Okay. Sir, I would like to thank you from the bottom of my heart, from all my walls, including aortic, mitral, tricuspid,
and Sanjay Fiber at all.
to express my gratitude for this wonderful CME. I am sure my fellow physicians would have taken some important carry-home messages. For me, there are 2-3 important things before I give it to Dr. Kalra sir to summarize. Structural heart diseases today are extremely important in a physician's practice. Once we diagnose a case with a valvular heart disease, we are duty bound to consult a cardiologist, oblique a CTVS surgeon for prognosticating and for following up, for future follow-up of all these patients. In today's world, good therapies are available, including procedures like TAVI and microclip which you mentioned, although they are very costly. For me, the message is that if I want the same biological prosthetic tissue wall to be put in my patient, and if I convince him to get it done surgically, he is going to save a lot of money. So, as you mentioned it in one of your talks, you buy a Mercedes at the cost of a BMW. If I remember your sentence correctly, sir, I give it to Dr. M L Kalra sir to summarize it for all of us.
Sir, वैसे तो आपने इतना सारा प्यार से समझा दिया, कुछ ज़्यादा कहने की बात नहीं है. What I understand is, when we come across a heart patient, so patient is having either valvular problem, vascular problem, muscular problem, or conduction system problem. So every time we have to involve a specialist. Maybe a cardiologist, interventionist, or a surgeon like you, where everything else fails, you are the boss. Then you have to give us the support that you will take care. When medicines fail, intervention fails, and there is no other chance. So we are calling back for you, sir, for yet another CME. अभी आज कुछ ज़्यादा समझ में आया नहीं है. मैं मजाक कर रहा हूँ. आपने जो समझाया वो तो आ गया. अभी बहुत कुछ बकाया है. अभी बहुत कुछ बकाया है. आपका पिछली बारी का भी बकाया है. तो अभी 2 बकाया इकट्ठे हो गए तो 2 CME की बात है. Anyway, तो एक तो हो गया. वो जो बाहर जाके आपसे बात करने का मजा आ रहा है.
I must mention that whenever I have asked requested Dr. Rajneesh to do a CME for us, answer has always been yes. It's been a week here or there because of his own exigencies at times, but the answer is always yes. 2 people in Max where the answer is yes, I have never heard a no. Dr. Viveka and Dr. Rajneesh now. So thank you very much, sir.
Thank you, sir.
And